Then the next speaker is Dr. M.L. Bera, who is also joined Fortis Group of Hospital in Gurgaon. Is it right, sir? Fortis? He was in Apollo, but he joined Fortis Group of Hospital in Gurgaon recently. He's a great guy who believes a lot in the CT scan and MRI. Now let's see what he has to say. Dr. Bera.
Hello, respected chairpersons, and good afternoon, everybody. After the two very prominent, eminent speakers, now my task has become very difficult. In this session, I will be discussing about the CT and MRI and their application in the cardiac diseases. Both CT and MRI have shown tremendous growth during the last decade. CT from single slice to go on up to 640 slice, and with the tube rotation time less than 300 milliseconds. Similarly, MRI has also progressed from 0.5 Tesla to 3 Tesla MRI with the complete digitalization of the data acquisition system. That has led to tremendous potential for evaluating the pulsating hearts, and during the last 2 years we have seen tremendous literatures working on the evaluation of the angiography as well as various functional as well as physiological status. So cardiovascular disease remains the leading cause of death worldwide. The prevalence of CAD is increasing in developing countries. In India, the prevalence of CAD is almost 4 to 6 times higher than any other ethnic group. More common in younger generations. 40% of the patients are less than below 40 years of age. Chest test is the commonest presenting feature in CAD. Patients with chest pain often go through a series of diagnostic tests in the primary diagnostic workup to rule out the CAD, that like ECG, ECO, TMT, enzyme test, PET, and sometimes cath angio. So in the clinical workup, the current status is the clinical history and non-invasive diagnostic techniques documents presence and severity of disease only and does not provide comprehensive morphological and functional information needed for therapeutic planning. Often require additional tests like nuclear scanning and or catheter angiography for morphological as well as functional and physiological information. Catheter angiography is considered the gold standard of diagnostic tests, but it is invasive and carries risk. Similarly, isotope scans have higher radiation hazards. So now there are various issues in related to multiple tests, like what is the patient's pre-test risk for CAD, how accurate are these tests, are all these tests needed, what are the costs and effects on health outcome of each test, does special considerations make one test more suitable in a specific patient. These questions come from patients, from the insurance companies, from the referring doctors, so various questions you have to face. So now MRI and CT both are non-invasive and increasingly used in the primary diagnostic work of CAD. Various applications, they include morphological imaging like coronary calcification scoring by CT, vascular anatomy, detection of stenosis, plaque analysis. Yesterday it was very nicely demonstrated, given lecture, assessment of myocardium for its thickness, its enhancement pattern, functional assessment like myocardial contractility, akinecty, dyskinesia, chamber volume, ventricular ejection fractions, perfusion studies, rest and stress perfusion with dobutamine or adenosine to look for inducible ischemia, infarct or viability testings like delayed post-scan. These are the various protocols available with both CT and MRI for a comprehensive evaluation of the CAD. Guidelines. So before going, what are the guidelines available for operating these machines for evaluation of CAD? At national level, we don't have any guidelines. Only guidelines we have is the American Heart Association that says neither CT nor MRI should be used as a screening tool in asymptomatic patients. Potential benefits of non-invasive coronary angiography is likely to be greatest in asymptomatic patients with intermediate risk factors for CAD after initial risk stratification, including patients with equivocal test results. Diagnostic accuracy favors CTA over MRA. CTA and MRA is not indicated in high-risk patients. MRA is favored for anomalous coronary artery evaluation. Reporting of coronary CT and MRA should include description of anomaly, technical quality of examination, vessel size, and significant non-cardiac findings within the field of view. Continuous research in non-invasive cardiology is encouraged.
Use the mic.
So, value technological advancements now made it possible to image entire heart during single dialytic phase. MDCT is well established imaging tool for evaluation of coronary vessels. MDCT can equally perform cardiac functions, perfusion studies, and myocardial viability tests comparable to other modalities. This is the Core 320 study 2012 that gives accuracy of CT and CTP at par with other par, that is cath angio and SPECT MRI. Benefits, and this is the comparison between CT and MRI. Scan time, very few seconds CT angio, MRI takes 6 to 10 minutes, data acquisition, volume data, various parameters, imaging parameters, so I will skip through it. This is the CT angio plane to evaluate the coronary calcium load. This is the CT angiogram for morphological study, definitely depicts much better vascular anatomy, including the small vessels, and you can see the interluminal pathology if at all. This is the myocardial depiction of the myocardium as well as the various vessel inner pathology, and it can detect the luminal stenosis accurately. This is the case which middle-aged lady has come with a frequent chest pain last 15 years. Is an employee of our hospital. I had the CT angio. Here I could get the anomalous or the RCA from the left main and interposed between the ascending aorta, the right ventricular outlet. That is giving rise to frequent pain. So this is a video clip, possibly not functioning. So this is a very young patient who has come with chest pain, so it's triple vessel disease. You can see the plaques in LCX, in LAD, in RCA, multiple full of plaques. So this is the two cases post-stenting. One is LAD showing infarct in the anterior myocardium. Down below one the LCX, again showing infarct in the myocardium. There is perfusion defect. This is another case, again chest pain. This is the fast angio showing myocardial perfusion defect. So this is the patient which was done CT angio showing multiple calcific plaques and very difficult to determine the luminal stenosis. Now perfusion study does not reveal any perfusion defect, hence that gives accuracy about the angiographic findings is in non-flow limiting stenosis. This is the comparison of the SPECT myocardial perfusion with the CT angio, both in the stress test showing anterior myocardial perfusion defect. In the rest, there is a very minimal perfusion defect, both is well seen in the SPECT as well as in CT angio. This is the MRI 3D picture showing coronary arteries, but smaller vessels are poorly visualized. This MPR image is showing the major vessels good, but small vessels are not visualized. This is again MR angio. There is a definite filling defect in the LAD, and that is been well correlated with the cath angio findings. So this is the stress and rest perfusion MR studies. In the upper one, stress test showing perfusion defect myocardial. In the down rest one, it is already showing, so it is a reversible ischemia. This is the chronic infarct showing various myocardial thinning in MRI. Fusion imaging, PET and PET CT and PET MRI, both MRI and PET has a definite role. PET CT is a non-invasive oil-validated imaging tool for cardiac imaging. It offers simultaneous evaluation of morphological, functional as well as physiological parameters of hearts. But it has got high radiation, both from the radiation from the CT as well as isotopes. MRI has promising future. Initial animal study reports are quite encouraging so far. Cardiac studies need to be watched in the future applications. This is the PET CT angio, is showing, demonstrating the vascular anatomy with stenosis of the LAD, but perfusion status is very minimal perfusion defect, and functional studies post-stats is showing tremendous increase in the output. So this is Dow flow limiting but showing excellent functional studies. So this is another PET CT image with three-dimensional model, complete total blockage of the LED, that is LED, LCX, and this blue map is showing the perfusion defect in the supplied area. So this is the application from the PET CT. So to conclude, both MRI and CT offer sensitivity and specificity compatible to those of catheter angiography and nuclear imaging tests. They achieve resolution better than that of nuclear imaging, and they can demonstrate the coronary anatomy compatible to catheter angiography. Both MRI and CT complement the combination of nuclear imaging and catheter angiography findings in the same sitting, avoiding risky invasive catheter angiogram and high radiation to patients from the nuclear imaging. Both MRI and CT have the ability to replace the time-tested imaging tool for evaluation of CAD and likely to form the future platform for one-stop shop in CAD evaluation. Thanks.
Thank you very much, Dr. Bera. I think you brought very important issues, the hazards of radiation and the implication of MRI and even the fusion imaging, which is a future role. And you mentioned very nicely about one aspect of MRI. We can pick up the anomalous coronary artery very sensitively. I think we'll have a discussion a little later. Please join us. So ladies and gentlemen, now we have the last guest lecture and a short presentation by Dr. Y.P. Sharma, who is the Director of Cardiology in PGI, Chandigarh. I'll request Dr. Sharma to have his presentation on cardiological aspect of cardiogenic shock. We heard before lunch from a critical care guy how to manage cardiogenic shock from critical care perspective. Let's see what cardiologist has to say. Dr. Sharma.
Thank you, sir. It's my privilege to present this data. In fact, I am really thankful to Dr. Chopra, Dr. Prashar, Dr. Gupta for inviting me here. It's my second time when I visited this place. It's really very beautiful. The lectures are very good. I'll be just presenting a very short because already something was discussed regarding this. I'll be, I think, very fast, maybe 7-8 minutes. I'll skip many slides. But there is a paradigm shift. What we are seeing since 2003, there was a consistent decrease in cardiogenic shock mortality. We were seeing earlier alternate patients succumbing to mortality. Then sometime we saw 8 to 9 patients surviving continuously. So then we started working on this. We gave thesis to our DM patient, and we could achieve a landmark success in decreasing the mortality of cardiogenic shock. I'll just tell regarding the previous one, introduction of shock registry, what is the mortality before and what we have done. In fact, this definition of cardiogenic shock, I think I should not tell, everybody knows. This is a mechanism of cardiogenic, it is a vicious cycle. If you do not break the vicious cycle of hypoperfusion, ischemia and hypoxia, it continues and there is a myocardial expansion and leads on to the cardiogenic shock in the hospital. Because majority of the patients sometimes present with first episode of cardiogenic shock and some develop during hospital stay. If you see in ST elevation MI 8% cardiogenic shock present, in NST MI 2.5% and mortality to the tune of 40 to 70%. But usually mortality is 60 to 80% in shock registry. These causes are already discussed. If you see the risk factors, age more than 55, female, large anterior infarct, clip class 2, BP less than 90 and heart rate more than 100. Thrombolysis is not very effective as it's a pressure dependent, but in some of the cases where PCI can never be done, the right approach is to give thrombolysis or 2B3A, which I will show you later on our result. The mortality in cardiogenic shock is to the tune of 60 to 80%. It is just like a sword on the head till it falls on this one and the patient is dead. Because cardiogenic shock with BP of 30, 40 coming in CCU or emergency, it's really challenging. The lessons from shock trial were, it was in 36 centers, 119 patients, 302 were randomized and 152 were each in arm. The mortality was 60%. In ventricular septal rupture, the mortality was 80 to 87.9%, 3%. And this data I will show you then later, that with ventricle septal rupture, we could save the convective 7-8 patients, and there was only one mortality in the last patient. This is a medical treatment because there is no guideline. It is a consultant decision depending upon the patient. So if you see, the 3 vessel was majority in those, 2 vessel followed by single vessel. Revascularization at 30 days was better trend in shock trial. There was a trend of increase, better with medical treatment in patients with more than 75 and in female patients. With multivessel PTCI and cardiac shock, the 1-year survival is 27%. Single vessel, it's better. The principle, everybody knows that you have to maintain the tissue perfusion. It is very thin. The right interpretation of the investigations, right selection and right approach can save the patient. As already discussed, norepinephrine, vasopressin in selected patients is better rather than giving dopamine in very high dose. You start the dopamine in low dose, but definitely fluid challenge. There was a question there, how much fluid in raised LVDP. When LVDP raised, don't care for, give slow boluses. If the blood pressure is increasing, heart rate is decreasing, and patient is becoming better, 50-50 ml fluid, and if give Lasix, never deprive the patient of fluid, because if you deprive with fluid, immediately the urea starts rising, and then creatinine starts rising. You do not know what was the baseline urea. It may be 20, 30. When it is even 45, you should be very cautious. And only when the renal dysfunction occurs, the cardiac shock becomes in the irreversible stage and myocardial performance further decreases. So right interpretation of even TLC, early infection detection, early treatment, because already if counts is 11,000, never wait for 10,000, rather patient is toxic, look, start some antibiotic, never wait for two days, immediately evening, next day, see morning, what is the count, give antibiotic, replace, add. When the counts start decreasing, rather than interleukin 6, TLC is such a parameter which can tell you that patient is not going into toxemia, because toxemia further decreases this blood pressure and it leads on to infarct expansion and multi-organ damage. So inotrope is very important. These are the various modalities already discussed, but IABP threshold in a patient which is there should always be there, because when blood pressure is 40, you cannot wait. If you give fluid, give this one, see the response immediately in CCU with all precautions, same in cath lab, put IABP. The patient may have blood pressure increase and see whether IABP is working right and there is diastolic augmentation, not otherwise, because it may harm if it is a systolic augmentation. This hyperglycemia, which is in majority of the cases, patient taken for primary PCI without investigation can lead on to the disaster, because PCI is such a primary PCI, door to needle time, thrombolysis when no investigation, patient has come in a golden period. And if there is none and PCI is available, go for that with investigated patient, not in otherwise. Otherwise it can lead on to the mortality. If you see PCI, there was a trend towards increased cardiac shock, and they have not mentioned what was the outcome in that cardiac shock, because by exclusion there is always in every trial critical analysis, caveat, limitations, some motive. You have to be very careful for reading any trial, otherwise the trial can mislead you. But definitely in selected patients, PCI immediately is better. But if it is not, go for alternative. PGI experience, as I showed, we gave a DM thesis, and we could see even those patients who were excluded, like elderly, in with rupture, ventricle septal, we included all patients. And we saw what is the real outcome of cardiac shock, because this was an area of interest where we cannot say that patient has to go for medical treatment, patient has to go for alternative. It is a real question of life and death within few days or few hours. So 40 patients of cardiac shock, mean age was 56 plus minus 7. There was a male predominance, and ST elevation was present in 85%. This the age was more between 50 to 70 maximum patient, but the patients were in 30 to 40 also, and 3 patients in more than 70. So VST was present in 3, but later on we included, there were 4 more patients, 7 patients, this one I will show. The thrombolysis was there in 14 patients, paraffin we gave. Suppose patient has come after this, low cost 2B3 inhibitors. Immediate patient slightly stabilizes. After that you can go for angioplasty or surgery. Like that. Sometimes the BP improves. The surgery was done in 12 patients. This vessel disease was triple vessel disease in majority. Mortality, we had 16 patients, mortality 40%, by including those patients, VSD, elderly, and the early onset of shock. These are the factors predicting mortality. PCI increases mortality in patients more than 75 years. Mortality experience in PGI with left ventricle failure, 15 patients with left ventricle failure, ventricle septal rupture, no mortality, acute MR, 1 patient that died later on because of sepsis during hospital stay after surgery. The ventricle septal rupture mortality in the shock trial was 87.3%. This is our ventricle septal rupture. They were some, it is not that immediate surgery, delayed surgery. There are so many conflicts. Earlier there was delayed surgery, now immediate surgery. Surgeon never takes up. Many approaches are there. But definitely if you can stabilize the patient in a well way, surgeon then takes, the outcome is really same as VSD, just as normal VSD. Because surgeon earlier were not taking up. But later on they said, you decide when we take up the patient. But definitely when the patient went up, they went in a very stable position, some at 21 days, some at 16 days. So we have a more than 1 year follow-up of these patients and they are really doing very well. Acute MR, we had one patient only that succumbed to infection. So this is a case which presented in cardiogenic shock. The LED was totally occluded. We immediately put IABP and took the patient cath lab and did angioplasty. Incidentally, she had fungal granuloma on the chest. The vessel was opened. Later on, she had NSVT and some syncope. After 1 year, we gave her AICD. So conclusion from our study, the mortality can be decreased if there is a right approach in the right person and right selection and right interpretation of the investigations. Because there are so many flaws, reforms are going on for values, for other things. Even in NEGM, first is reform policies. Because lot of things were generalized and some of the things which are in the West doesn't apply to the Asia. The genes are different, environment is different. There the people are so malnourished, the protein level is so high. If you give them protein, the receptors are not there. Immediately this one pressure starts increasing and they become better for surgery. So basically my take home message is the cardiogenic shock mortality, which was considered to be high and leaving the patient just mortality is not high, it should never be there. We should rather not doing the angioplasty in 50, 60, 70%. Rather save these patients so that net outcome of the patient survive becomes more. And those patients who can be managed on medical treatment or otherwise by making the hemoglobin more or building up the patient, they should never go for this one intervention.
Thank you very much, Yash. I think it was a very lucid and a very outstanding presentation with showing a mortality of almost 40% in cardiogenic shock and a huge data. I think this is a very nice and a very versatile data from the PGI Chandigarh. You need to be really appreciated for following up of the patients also. I request you to kindly join us on the dais.
Thank you.
I'm sure there will be some questions now from the audience. I could see Dr. Muralidhar Rao. He has some question. Yes, sir. Give the mic, please. Mic.
We are using levosmandin, but in these patients we never used. But 2-3 patients, other patients of VT storm, LV dysfunction, very poor LV, in that requiring in this trial we have not used, but later on, now we have used in 2, about 2 weeks back. One patient is still admitted. He was having VT storm, ejection fraction 17-18% and creatinine. We gave combo about 3-4 days back. And he's doing well.
Dr.
I might have heard it wrong. You said your cases are post-MI VSD. The more you delay, the more the mortality. So if I heard it right, many patients were operated many days or weeks after VSD or what? Suppose the patient develops a VSD with an MI. What will be your line of approach? And he is in cardiogenic shock.
These all patients presented with VSD with cardiogenic shock. So what we did, we try to make the patient stable by IABP, by giving this. Some of the patients we took for angiography and saw whether we can do angioplasty or not. But majority of the patients were having diffuse disease. One patient, even on medical treatment, he remained well. There was a diffuse disease. Cardiac surgeon couldn't do anything. He said, I will not do anything. And subsequently, the VSD became smaller because we know when there is a cardiac shock, BP is low, heart is dilated. In fact, VSD looks larger, but later on it can become smaller also. But definitely, when VSD is there, it should be operated. But that patient on medical treatment is still on more than 1 year follow-up.
Yes, what Dr. Parashar is asking, any patient who comes to us with acute MI with VSD, what is the maximum time you have waited in your series of patients, and what is the average time you subjected your patient for intervention like surgical intervention?
Yeah.
Answer you want, sir.
3 days, one patient went for surgery after doing and maximum 21 days. So because
21 days.
But definitely, this intra-aortic balloon pump, raising hemoglobin.
Did you do any of your patients' lactate levels while managing your patients? Did you do lactate, blood lactate levels? There was a discussion this morning.
We didn't do blood lactate, but ABG and other things, procalcitonin in 1 or 2 patients we did.
Did you do any interleukin 6?
Not interleukin 6, but with PLC only. Surprisingly, we didn't have, as in shock trial, there were 12% patients who developed renal failure. Rather, here, from creatinine of 2, subsequently the creatinine came down with better management of the patient.
Thank you very much, Yash. Any other questions or comments from the audience? Dr. Khanna.
So you were telling excellently about the cardiothoracic surgery. Some respiratory failure patients or respiratory functions which have been compromised, you have skipped those slides. Can you go through those 2-3 slides which were remaining if the time permits?
Please don't ask for going through for any slides. If any question or comment, please ask that. We are already running short of time. If there's any question or comment. If no question, comment, I think let's forget about it. Anybody else? I think, ladies and gentlemen, let's give a big hand to all the 4 speakers for doing a wonderful job, presenting outstanding data. And I think I'll request Dr. Parashar to kindly come on the dais to hand over the scroll to the learned guest speakers. Dr. Parashar, and I'll request Dr. Anand Khanna to join him, please.
Ladies and gentlemen, may I request Colonel Parashar to kindly present the first scroll citation to Dr. Mahapatra. May I invite Dr. S.N. Khanna. And Colonel M.L. Bera. Thank you very much, gentlemen. That brings us to the end of the proceedings of this session. I would request Colonel Parashar to kindly stay on to the dais as he is the last chairman of the last